part of session on clinical pharmacokinetics, concepts and application. In this second part, we will see about distribution. Now, as we have already told, we will look into the concepts of pharmacokinetics and how they are clinically applied. Let's go into this session. Let's see the first concept with relation to the distribution of drugs. The first concept I want to touch upon in relation to the distribution of drugs is that if a drug has to act, it should reach the site of action. Looks like a very simple concept, isn't it? Very easy to understand also. If a drug has to act, it has to obviously get distributed to the site of action, isn't it? Now let us see how this simple concept is applied and how we use it therapeutically. Now, let me ask you a very simple question. If we are going to use a drug which has to affect the central nervous system, what do you think should be the essential pharmacokinetic parameter of it? So, yes, so it needs to cross the blood-brain barrier and reach the site, isn't it? The brain, isn't it? So, the essential pharmacokinetic parameter of a drug which has to act on central nervous system is it should cross blood-brain barrier, right? So, the essential pharmacokinetic parameter for a drug which has to act at central nervous system is that it needs to cross the blood-brain barrier and gets distributed to the site of action, right? Now, are there any exceptions to this rule? Can we have a drug which does not cross blood-brain barrier but still can have its action on the thing? Please remember that whatever rules are there in medicine, there are also exceptions. So if you know the rule and the exception, you can very easily tackle it. Now, what are the exceptions? Can you think about any drug which cannot or which does not cross blood-brain barrier but still can act? Yes. Now, there is a group of drug called peripheral dopa decarboxylase, isn't it? So the name itself tells that they act only in the periphery, but it is used for a central nervous disorder called as Parkinson's disease. So the drugs like say carbidopa, and also there is a peripheral catechol O-methyltransferase inhibitor called as anti-catechol. So these are some of the exceptions to this rule, but by and large, if a drug has to act, it has to. So that's one thing. So if you want to develop a CNS drug, or if someone asks what is the essential property, it should cross blood-brain barrier. Now let's slightly take this principle to a slightly higher level. Now let me ask you another simple question. If you want to use an antibiotic for treatment of a patient with meningitis, now what should be the essential? So now our clinical condition which we are going to talk about is meningitis. Now, of course, again the drug has to cross the blood-brain barrier. Now there are two types of antibiotics which can be available, or antibiotics can be classified as three types. Now, an antibiotic which does not cross blood-brain barrier, does not cross blood-brain barrier. There are a type of antibiotics which freely cross blood-brain barrier, and the third type of antibiotic is they which cross only when the meninges are inflamed. These are the three types of antibiotics which we have. Now, let's apply. We have already told it should reach the site of action. So, these type of antibiotics have no role in treating meningitis. Now, which among these two will be preferred? What is the principle and how should we apply it in this condition? Now, many of you might think that antibiotics which cross the blood-brain barrier only when the blood-brain barrier is inflamed might be a good choice for treating a patient with meningitis, because we might think, okay, it will go only when it is inflamed and it's a beneficial property. Now let's look into it more carefully and see how this very simple concept is applied in different situations. Now, what happens when you select a drug which crosses only blood-brain barrier is inflamed? The initial part, the drug goes very well into the meninges, crosses the meninges, goes into the CNS. And as the day goes, as this disease starts getting cured, the inflammation also reduces. Now, what happens? The permeability of the drug into the CNS gets reduced. So now, we have to remember that for treating the patient or getting cured the infection, we need to maintain the concentration at a particular level for a duration of time. So what happens? This concentration which needs to be attained for that particular day will be getting reduced unless we take care of this and increase the dose. So that's one problem which is inherently there with these type of drugs, antibiotics which are cross the blood-brain barrier only when inflamed. So when given a choice, always going for antibiotics which can freely cross blood-brain barrier, so that you need not worry as the inflammation subsides, will the drug reach or not. That will not be a worry at all. So please select these things if given a choice, that among these two kinetic parameters which is preferred. So that's another way how this simple principle is applied. I'll take you one more example of how this concept can be applied in another clinical situation, what we can say. Now, let us think about diuretic. Now let us have a diuretic. Now let's again apply the same principle of what should be the essential parameter or essential pharmacokinetic parameter for a diuretic to act. Now let's think. Again, we have told if a drug has to act, it has to reach the site of action. What should be the essential pK parameter for a diuretic? If you now ask me, what should be the site of action of a diuretic? It is the renal tubules. If you want to very specifically say the lumen, isn't it? So it should reach the lumen of the tubules. This is the site. Now, how is this property? How are we going to come to a conclusion? Now, all diuretics act mainly to the luminal side. If you look into diuretics, they have a very high, they are highly protein bound. So what? There are 2 or 3 ways of coming into the lumen. The first way is through glomerular filtration. If a drug is highly bound to protein, it cannot be filtered. So it cannot come through glomerular filtrate. So the other way how it can come is, it can be secreted into the tubules. Now how it can be secreted? It is usually through organic anion transporter. So there is a transporter which secretes the diuretic into the lumen. That's how the drug reaches the site of action. So all diuretics essentially needs to be secreted into the tubule for its action. Now, I have already told you there are rules, there are exceptions. Now, is there an exception to this rule? Yes, of course, there is an exception. Now, if you look into the diuretic which does not act from the luminal side, that's a diuretic aldosterone antagonist, spironolactone, whose receptors are intracellular. These are steroid receptors, isn't it? The aldosterone. So these receptors are intracellular. They cannot act from the luminal side. They have to come from the interstitial side, from the blood. They have to cross and come into the cell and act. So those kind of drugs or those kind of diuretics are an exception to this rule that they need to be secreted. Right. Now, what is this application? Right. Now we have brought the drug into the human. So what? How this simple concept is applied therapeutically? Let us see that. Now, let us take this diuretic now. When can this secretion of the drug into the human can be affected? Let's think that. So now those clinical conditions you will not be able to make the drug work, isn't it? Now let us think this condition. What happens in renal failure is that the uric acid levels are high. Uric acid is also transported by the organic anion transporter. So now what happens? Not only the diuretic, the uric acid also now competes with the organic anion transporter for its secretion. So in a patient with renal failure, so inherently it becomes very difficult for you to bring the drug to the site of action. That's why in a patient with severe renal failure, many diuretics don't work. So that's very basically based on this principle that if we can't bring the drug to the site of action, drug will not work. So these are the three ways or three applications of this simple concept that drug should reach the site of action, otherwise it can't work. Right? So that's the first principle or first concept which we have seen. Now let's see the second concept of this related to distribution and see how it can be applied therapeutically. Now, the second concept which we are going to deal today is about the apparent volume of distribution. So what is meant by apparent volume of distribution? Let us now see that with a small example. Now, let me try to explain to you what is meant by apparent volume of distribution. Then we will see the concept and see how is it applied. Now let's come to this first example. I have a small jar in which I know the volume of this jar. Let's take the total volume of this jar is, let's say, 3 liters. So I have some water. I add a drug. I know the dose. I add 1 gram of drug into it. It gets dissolved. Now what do? I take some small sample from it, try to measure what is the concentration, and I found out that it is 0.5 milligrams per ml. Now, if I ask you what is the volume of water in this small jar, we can easily find out, isn't it? 1 ml has 0.5 milligram, and so to get a total of 1 gram, the total volume will be 2 liters. Am I right? Now, let's take another example. Now I have the jar. Now what I have done, I have put on small fish into this jar. What am I going to do now? Now again I am going to add this drug, 1 gram of drug into it. Now what this fish does is, fish eats up some amount of drug. But I don't know that there is a fish or it eats up some drugs. some amount of drug. Now again I take small amount of water from it, measure the concentration. Now it comes to 0.1 milligram per ml. Now what will be the volume if I have to calculate? So here 1 ml has 0.1 milligram. How much I added? I added 1000 milligram, 1 gram or 1000 milligram. So the volume here should be 10,000 ml, isn't it? So if it had been 10,000 ml, then only if I add 1 gram, it comes to 0.1. So it is volume should be 10 liters. That's what I conclude. The same amount of the jar volume didn't change at all. The maximum volume of the jar was actually 3 liters, isn't it? But now I am saying that it looks as if the drug is distributed in a volume of 10 liters. But actually if you look into, even the jar can hold a maximum of only 3 liters. Now this is exactly how we calculate or how we interpret the volume of distribution. Now it looks as if it is distributed in this thing of 10 liters, isn't it? Same way, that's why we always add the word apparent. It's a hypothetical volume in which the drug looks homogeneously distributed in the body at the same concentration of what is found in the plasma. So this is just a hypothesis. So if you look into, there are drugs which have, let's say for example chloroquine. The volume of distribution is 13,000 liters in a 70 kilogram man. This is much greater than the volume of the total body of a 70 kilogram man itself. That's why this is called as apparent volume, right? Are we clear about what is, how do we calculate this volume of distribution and why we say this is apparent and not a real volume? Now let's come to the concept. Now if volume of distribution is high, then what does that mean? If volume of distribution is high, then the drug is distributed to many organs. Many organs or many structures. Now this is again a very simple concept. The converse is, if volume of distribution is very low, then it is restricted into the intravascular compartment itself. Now let's see the applications of it. Now the first question is, why should a treating physician be aware of this concept, or why should a treating physician be aware of what is the value of volume of distribution of this drug? Now let's come to that. Now, if you look into, or if a drug has high volume of distribution, it is distributed to many organs, isn't it, right? Now, we have a drug with high volume of distribution, but we want the drug concentration to be attained to a higher level quickly. Now what should we do? How is this? So if VD is high, means it is distributed to many organs. So the plasma level will slowly increase, because if you put say 100 milligram, each part of it will be go to many organs, the plasma level will be very less. But I want the concentration to be high so that the action can start at a rapid, the onset can be fast, so that it can start its action fast. Now, how can we do about that? So this comes to the concept of what we call as loading dose. So for drugs with high volume of distribution, what do? If we want the action to start faster, we give a dose which is called as a loading dose. We give a high dose so that more drug, or the concentration which we want to attain in plasma is attained at a faster rate, and then we give a maintenance dose. So when you think of someone asks you what is the essential pharmacokinetic parameter of drugs which require loading dose, they all have a high volume of distribution. That's why if you look into the formula, even if you look into the loading dose equal to volume of distribution into target concentration. So what is the concentration you want to attain times the volume of distribution. So drugs, if you know that a drug is having a high volume of distribution, then if you want to make the drug action onset fast, then you need to always put a loading dose. Very classical example is, as I told, is chloroquine. Chloroquine, as I told, is one of the drugs with a large volume of distribution. In a 70 kilo man, it is 13,000 liters. Now, how do we give this chloroquine when we try to treat a patient with malaria? Now, if you see, we have to start the action fast because malaria patients have a lot of symptoms. We need to act fast, isn't it? So the condition also wants the drug action to start, but the drug has a large volume of distribution. How we give the dose? If you look into chloroquine phosphate 1 gram stat. So we give a dose initially 1 gram chloroquine phosphate. Then at 6 hours we can give another 500 milligram 6 hours. Then another 500 milligram at 24 hours. And another 500 milligram of chloroquine phosphate at 48 hours. So this is the loading dose. Please remember that if you are going to give a oral loading dose, again volume of distribution into target concentration by oral bioavailability. If it is going to be oral, or if you are going to give intravenously, this does not come into the play. So this is a very classical example of how our idea that this has a high volume of distribution is applied here. This is one way that our idea or the concept of volume of distribution is required in treating or making a regime for a patient. Now, let's see the second application. Why should a physician know about volume of distribution? The second application is that for drugs with, again, high VD, if a patient has taken or been poisoned or if a level has gone into high, hemodialysis will not help. Because as we can show, it's a high VD means it's distributed to many organs. The drug is there in many tissues and organs. So if you just do a hemodialysis, it's not going to work at all. So that is another place where this small concept of if we have a high VD distributed to many organs is applied clinically. So that's the second concept. Now let's come to the third concept. This third concept is actually a converse of the first concept which we saw, and how this is applied clinically. Let us have a look at it. After initiation of action, after the action is initiated, the drug action action is initiated. If the drug moves out of site of action, moves away from the site of action, its action will be terminated. Now let us see how this concept is applied. Now this full sentence or this concept is given a simple term, what is called as redistribution. This whole concept The name itself tells distribution is being given to many organs, isn't it? So once it spreads, it's again from the site it gets redistributed. That's what the meaning. Now, a very classical example of how this concept is applied comes in thiopentone. This is an anesthetic agent, so it crosses blood-brain barrier very rapidly. So hence it induces anesthesia. The onset of anesthetic action is very fast, so it's a very good induction agent because it crosses very fast the blood-brain barrier, goes into the brain and starts its anesthetic action. Now what happens? It gets redistributed to, where does it get redistributed to? Fat and muscle. So once it goes into the blood-brain barrier, starts its action, it gets redistributed to fat and muscle, and hence its action is terminated. Now you can see here, it's a very good induction agent, but it cannot be used for maintenance. So that's the simple. So if it goes to the site, it acts, and after it starts action, again if it comes out of the site, its action is terminated. A very, very simple concept to keep in mind, and when you see this drug moves away, it always loses its thing. So a classical example is thiopentone. Now let's see the fourth concept related to distribution of drug. If a drug is stored in a particular structure or organ in the body, it can act for a long time. Very simple concept, isn't it? If a drug is stored in the body, its duration of action is long, or its duration of action is not dependent on elimination T-half. We can put it in that way also, because the T-half is one parameter which dictates how long the drug acts. But that's an exception. So if drug is stored, then if we have an idea about elimination T-half, it will not give you an idea about the duration of action. Now let's see how this simple concept is applied. Let's take an example of a drug called levodopa. Now you all know that this is a drug which is used for the treatment of Parkinson's disease, isn't it? So let's take a small dopaminergic neuron. Now what happens is levodopa is converted to dopamine. And what does this dopamine? So this dopamine is stored inside this vesicle. So levodopa, when we give for treatment of Parkinson's, it gets converted to dopamine. This levodopa crosses blood-brain barrier, comes into the brain. Inside the neurons, it gets changed to dopamine and stored in the vesicles. So whenever needed, this dopamine can be released and it can act on dopaminergic neurons. So this is what happens initially. Now the T-half or the duration of action is around 8 hours initially when you start a therapy in a patient with Parkinson's disease. You all know that Parkinson's disease is a neurodegenerative disorder. When we diagnose, the patient might have 70% of working neurons, dopaminergic neurons. As the time passes, 70% becomes 60, 50, 40. So the number of neurons also keeps on decreasing. So what happens? The amount of drug stored also is keep on reducing. So what worked for actually for 8 hours, as the disease progresses, will slowly start working for 7 hours, 6 hours. So what we call as the wearing off effect. So the drug dose slowly wears off. So it becomes 7 hours, 6 hours, slowly it keeps on reducing. Now what happens? More and more neurons keep being destroyed as the process of the disease. At one point of time, whatever dopamine which is converted, whatever dopamine is formed from levodopa, will all at one particular time. Nothing will be stored. So either it will all act, which is called as on period, and later on what happens? All levodopa is converted to dopamine. It just acts that, and that's all it goes. So rest it becomes off. So as the disease progresses, the duration of action also reduces, and it leads to what is called as an on-off phenomena. Why all these things happens? With a very, very simple point that if a drug is stored in a body, its duration of action is long. So as it is not stored, what happens? The duration of action keeps on decreasing. So this is a very classical example of how this very simple concept is applied. So now, how do we tackle this problem? We cannot increase the number of neurons, so we try to prevent the degradation of this dopamine. So we add either MAOB inhibitors or COMT inhibitors to tackle this type of adverse effect as it comes with dopamine, levodopa. So this is the fourth concept. So now, to summarize what have we seen, we started with 4 concepts. The first concept is that if a drug has to work, it has to reach the site of action. Very, very simple concept. We saw that, so the essential pharmacokinetic parameter of a drug which affects central nervous system is that it has to cross blood-brain barrier. We extrapolated the same concept to an antibiotic for treatment of meningitis. We saw that we have to prefer drugs which freely cross blood-brain barrier compared to drugs which cross blood-brain barrier only when it is inflamed. The third application of this simple concept is that we saw that in some disease condition, we took an example of diuretic. If the disease condition is hampering the distribution of the drug to the site of action, then the drug cannot work. A classical example of how diuretic comes to the site of action through an organic anion transporter, and in renal failure how this can be affected and how the response to drug or diuretic can be hampered. That's the first principle which we saw. The second principle which we saw is about the apparent volume of distribution. We saw why are we saying it is an apparent volume. We had a very simple analogy of a small jar in which we first just added water and tried to find out the volume, and we had a jar in which we had fish. So this jar is our human body, and this fish, there can be multiple fish. One fish can take a role of liver, spleen, CNS, bone, tissue, muscle. So we have a lot of fish which we don't know which fish will take how much of this thing. That's why the apparent volume of distribution sometimes becomes so large which exceeds even the volume of our body. And the second concept which we saw was, if the volume of distribution is high, then it means it is distributed to many organs. How this is applied? If we know that a drug has high volume of distribution, and if the clinical condition warrants an immediate onset of action, then we should always give a high dose, so that a quick plasma volume, the plasma level can be achieved higher quickly, what we call as the loading dose. Right. The second way how this high VD concept is applied is that if a drug has high VD and the patient has toxic level, then hemodialysis certainly is not a solution. So that's the second concept which we saw. The third concept, we again took the first concept and took the converse of it. First concept is, if a drug has to work, it has to reach site of action. The converse of it, after the action is initiated, if the drug moves out of the site of action, its action is terminated. We saw a classical example of thiopentone starts its action immediately as an anesthetic because it crosses blood-brain barrier fast. Same way, it gets redistributed to muscle and fat, and hence its action is also terminated and short-lived. So it's a very good induction agent, but it cannot maintain the anesthesia for a long time. So that's why we use thiopentone as only as an induction agent. The last principle which we saw was about if a drug is stored in a body, then its duration of action is long, and the elimination t-half will not give an idea about the duration of action. We saw a very classical example of a drug being stored in the body, levodopa converted to dopamine, stored inside the vesicles. So once there are enough neurons, it acts for 8 hours, and the number of neurons keeps on reducing. The duration also very classically keeps on reducing. What was 8 hours becomes 7, 6, 5, 4, and at some time there are no neurons that can store dopamine, and so all dopamine which is got from levodopa acts, which is called as on period, and later on it's just off. So that gives to on-off phenomena. So these are the 4 concepts related to distribution of a drug and how these simple concepts are applied in a clinical practice. We saw about this in this session. In the next session, we will continue with how metabolism of drug can affect or can play a role in deciding the therapeutics of things. That will be in the next session. If you have any doubts in this session, please get back to us. Thank you very much.